What is asthma?
Asthma is a lung disease that you can get inflammation in the airway, you can get narrowing of the airway and excess mucus production, and that causes some obstruction of airflow through the lungs, and is usually in response to some sort of trigger. It could be an allergen or some sort of environmental trigger. And the symptoms are that the person who's suffering from this will get wheezing, coughing, sometimes shortness of breath, and chest pain.
Okay. And so it's like an obstruction of the airways.
Correct.
Okay.
Correct.
It's something that's very nebulous for me. I just don't know too much about it. So I always thought that you have to be wheezing to have asthma, but you mentioned a very interesting symptom, and that is coughing. So a lot of kids who have this cough can also be asthmatic.
Yeah, so the symptoms of asthma can be, often it's both, it's wheezing and coughing, but there's some people who have what we call cough variant asthma, where their symptoms are just coughing, and they don't wheeze so much. So, sometimes if they're just coughing a lot at night or with exercise and things like that, then that can kind of clue you in if your doctor is taking a history, if you're having a chronic cough, that they may actually be suffering from asthma symptoms.
Okay, good to know. One thing that we need to know about is that asthma is actually one of the most common chronic disorders in children, and it affects about over 7 million children under the age of 18 years. And it's also the third leading cause of hospitalization among children under the age of 15. Wow.
Yeah, that's correct. And, it accounts for a lot of school days missed too.
Right.
School days missed and a lot of days missed from work from parents. So, like I said, it's a prevalent disease. It's very common. Fortunately, most people who do have it have a milder case of it. At least most of the patients I see. But it can cause severe restrictions in your life and can lead to many hospitalizations and even lead to death in some cases.
Now, is it different in kids versus adults?
Well, the disease process, like we talked about, the inflammation, the obstruction of airway, that's the same. And the medications we use to treat it are the same, although we use them in smaller doses. The difference is because kids have smaller airways, they can be affected by it more seriously. Because if you're having inflammation and mucus plugging and you've got a smaller airway to begin with, you can have more severe symptoms. Also, kids, they tend to get sick a lot more than adults do. Kids who are in daycare or school. So, being ill or having some sort of viral illness, that can also predispose you to having some of these asthma symptoms.
Okay. And what are the causes? And now this is like a huge multifaceted question.
Yes.
So what are the causes? What are the triggers? What's the relationship between allergies and asthma?
So allergies different allergens can set off your asthma symptoms. So if there's things you're allergic to, like trees or pollens, animal dander, things like that, those can all trigger your asthma symptoms.
Really?
So there is a relationship between allergies, asthma, and also eczema as well.
Oh, really?
Yeah, so all three of those. So, but there's other things also that can cause it. And younger kids, a lot of times, when they're sick, like we talked about, viruses like an upper respiratory infection or lower respiratory infection can trigger wheezing symptoms. Sometimes other environmental things like cigarette smoke is a big one that can cause kids to wheeze. Pollution can cause kids to wheeze. Sometimes even just perfumes or certain kind of strong smells like cleaning supplies can set off. So there's multiple different triggers that can cause you to wheeze. And for every person, that may be a little bit different. The most common ones, I would say, are weather changes and exercise. Those are and colds or some sort of illness. I'd say those three are probably the most common ones that we see. So do you expect to see asthma in any particular season, like spring or in fall, or is it a prime time for asthma in one of those two seasons? We see it probably more exacerbations in the wintertime.
Winter?
Yeah, just because because kids are sick more often. They may be having the flu and things like that. But we see it year round. I think we see a little bit more in the wintertime just because we see more illnesses in the wintertime. But you can get it anytime. And then, like I said, when there's weather changes, like it's changing from suddenly warmer to colder weather, then sometimes that triggers symptoms too. So when those seasons change, sometimes we'll see exacerbations then too.
And you mentioned cigarette smoke. Now, I presume that all these very young kids are not smoking, but they're still susceptible to asthma. So you're talking about secondhand smoke?
Yeah, secondhand smoke and also thirdhand smoke.
What is that?
Thirdhand smoke is just smoke exposure from like people's clothing or carpet and things like that. So even just minuscule amounts like that, especially in asthmatics who are very sensitive to that, it can trigger their symptoms. So that's a major risk factor for asthma symptoms, and for severe asthma symptoms is cigarette smoke.
Oh, so if somebody, let's say a mom or a dad is a smoker and they're like, oh, well, we don't smoke in the house, we step outside.
Right.
But they are actually carrying the allergens
They
inside.
are, yes. So it's in their hair, it's in their clothing.
Okay.
So just a child being around that person can be affected by that. So even if they're smoking outside. So oftentimes I'll tell parents who do smoke, the first thing I'll tell them is quit for themselves and for their kids. But if they can't quit, or if they're in a process of quitting, is when they do smoke outside, that they wear something over their clothes and then leave that outside, like a jacket or something, and don't bring it back in the house. And that'll minimize at least some of the exposure from the clothing.
Can't do anything about the hair.
Yeah, unless you take a bath every time you go smoke, which may be a good way to get people to quit smoking.
To quit, exactly. Yeah. Okay. All right. And now you also mentioned pollution. So I found this statistic which said that asthma prevalence in kids under the age of 18 ranges from 5.5% in Tennessee to 18% in DC.
Yeah, I think it can change according to where you live, and I think pollution is one factor. But I also think allergies is probably has to do with it also. So if you're in an area where people tend to get a lot of allergies, then they can certainly be having more asthma symptoms as well. Okay. So it's multifactorial. It's not just pollution alone. It's many things. Okay. The socioeconomic status also of people can affect, how severity of asthma symptoms as well.
Really? What about the Dallas area? Do you know anything much about the Dallas area?
I don't know what the exact number as far as prevalence is, but it's a big city, so it's going to be probably on the higher end of that.
Okay, good to know. What about hereditary? Is asthma hereditary?
It is. If a parent has it, then the child is 3 to 6 times more likely to have it. So there is a genetic predisposition to it. Okay. So if you have even like a cousin or someone else in a family that has asthma, then you're also more likely to have asthma as well.
Okay. All right. Very good. What actually can we talk a little bit in detail about what are the symptoms? You mentioned about wheezing, you mentioned about coughing. When we look at our kids, how do we know that they're actually experiencing an asthma attack?
Well, if they're wheezing, a lot of times you can hear that.
So is it wheezing when they're breathing in or when they're breathing out?
When they're breathing out, when they're exhaling, you'll hear at the end of the breath, you'll hear a wheeze, kind of like a soft whistling sound, and that's what wheezing is. So you'll see that, or you'll hear that when they're having some wheezing. Okay. Sometimes if it's mild, you may not be able to hear it, and it may be something that only the doctor may hear with a stethoscope. Okay. But coughing is one we mentioned also. But basically, if you're seeing them, feeling like they're short of breath, they seem like they may be breathing a little bit faster. They may seem a lot of kids look anxious because they're having trouble taking breaths in. So those are all kind of signs that could clue you in that they're having some difficulty breathing. And I think most parents who have asthma, and they're used to treating it, they're aware of these kind of symptoms and know when their child is having trouble. So when your child is complaining that I'm finding it hard to breathe, or there's my chest feels funny, you should believe them. You should definitely take them in to see your doctor to be evaluated. Okay. Now,
a lot of times in schools, they have the kids running, right? For PE and exercise and all that. So how do you know that it's just not a conditioning of the child that is lacking versus having an asthma attack?
Well, if it's just conditioning, they wouldn't wheeze with it. They may just be short of breath and say, I'm tired, but they wouldn't necessarily be coughing, wheezing, and feeling so short of breath that it would last. So for wheezing, it would last longer. So if you were just out of shape and you stopped running after a few minutes, you would feel fine. But if you're having asthma symptoms, that wheezing is going to last for some time after you're done. And the symptoms are going to be usually more severe. But it can be kind of confusing to differentiate sometimes because exercise or running often is a trigger, like we talked about for asthma symptoms as well. So sometimes it's a combination of both.
Okay. And what about chest pain? Does the child experience chest pain too?
They can sometimes. Usually we see that if it's more of a kind of serious illness or it's progressed. If they're just starting or it's a mild case, you typically wouldn't see that. But that is a symptom that you can see with asthma, especially when it's getting worse.
And loss of color in the child? Do they turn blue? Or
that would be
severe.
That would be.
You don't want that to happen.
Yeah, you don't want that to happen. That means you need to call 911.
Okay.
If they're getting blue in the lips, so that's probably an end at the end if it's really severe and they're having a really hard time and you haven't done anything about it, then you may see symptoms like that where they're getting low oxygen levels. So that's a pretty serious asthma attack, and like I said, you should call an ambulance if you ever see anything like that.
So a lot of times, for example, and I'm talking about kids, like both my sons suffer from it, they'll run, they'll go to the nurse's office, the nurse will call me and say and give me a figure for the pulse ox level. They said, we measured the pulse ox level and it was such and such. What does that mean, and what is normal and what should it actually be?
The pulse ox is just their oxygen levels in their blood, and it should be, usually it's not high 90s, like 96 to 100%, somewhere in there, but we want it somewhere over 92%.
Okay.
So if it's less than 92%, which we see sometimes in kids who are hospitalized or having a bad asthma attack, and sometimes we'll need to put them on oxygen.
Okay. And at what age does a child actually develop asthma?
It can be any age that we can see wheezing. It's hard to make the actual diagnosis of asthma in really little kids.
Okay.
So oftentimes, kids less than like 5 or 6, because some of the tests we do to diagnose it, they're unable to do those tests. So oftentimes we're just diagnosing it by history. But we call it, at that age, we call it something a little bit different, which is not exactly like asthma, but we call it reactive airway disease, which is wheezing just as a reaction to something like typically it's an illness, like a viral illness. So that just means that they have kind of temporary, short-lived symptoms, and oftentimes they outgrow it, and maybe just an isolated thing that may happen once or twice, but we don't want to label them as asthmatics at that young age. So typically we won't label them as asthmatics until they're a little bit older, usually like 5 or 6.
Okay. And when should you go and see a doctor? Which doctor should you go to? Should you go to your pediatrician? Should you go to an allergist? Should you go to a pediatric pulmonologist? And what are some of the tests that are used to diagnose asthma?
So if you suspect asthma, you should see your pediatrician first. And most pediatricians can handle the diagnosis and management of asthma. In more serious cases, your pediatrician may send you to a allergist to do some allergy testing or to do the test that we do for asthma.
Which is what?
The test we do is called spirometry, and that's a test where you blow into a tube and it checks your lung function and how fast you're breathing out. And they'll do that test, and then they'll give you a breathing treatment, an albuterol treatment, and then they do the test again and see what the response is. And that's the definitive diagnosis for asthma. And that test can be hard to do in little kids, which is why we said sometimes it's hard to diagnose little kids with it, because they're unable to do that test.
That's a very difficult test, honestly.
Have you done it before?
I see my kids do it, and I have them practice in the car all the way to the allergist's office. I'm like, you have to, learn to breathe out with this big tube sticking out of your mouth, and that's a tough test.
Are you talking about the peak flow meter, or are you talking about spirometry? Because those are two different things.
Okay, so tell me about both.
So peak flow is a little handheld device, that you blow into.
Okay.
And it measures, how much you're able to blow out.
That's the one.
Yeah, that one we kind of use to assess, if they're having an asthma attack.
Okay.
So that's a little portable one. Spirometry is a bigger machine.
Okay.
Where you blow into it and it checks a lot more different things and it graphs their lung function and things like that.
Oh, I see.
So that's a little bit of a different test.
I see.
Yeah.
Okay.
But you still have to blow hard
Yeah.
into it. So it's the concept of doing the test is similar.
Mm-hmm.
Yeah. And you're right. Sometimes even in older kids, you have a hard time. You have to tell them to take as deep breath as you can and blow out as hard as you can.
Right.
And a lot of kids have a hard time doing that, especially little ones.
Mm-hmm.
So like I said, that's why in little kids, a lot of times we're just making a diagnosis by their clinical symptoms as opposed to doing this test.
Mm-hmm. So go to your pediatrician first, and then the
Yes.
pediatrician will refer you to an allergist.
If you need it.
If you need
Yeah, if they're having severe symptoms or they're not getting better with the management that they've done, then they may send them to an allergist to do further testing.
Okay.
But I would say most of these cases can be handled by the pediatrician.
Okay, excellent. Good to know that. So now your child has been diagnosed with asthma and is put on some scary kind of treatment plan, which consists of these weird contraptions, the spacers, the different kinds of inhalers, sometimes nebulizers. So can you tell us a little bit about why all these different contraptions are used and a little bit about the medications used to treat the disease?
So in the beginning, we talked about airway inflammation and narrowing of the airway. So the most common medicine we use to treat those acute exacerbations is albuterol. Or sometimes we use something called Xopenex, which is levoalbuterol. And what that does is it helps to dilate the airway quickly. So when you get that narrowing of the airway and that inflammation, that'll help to open up your airway. So that can be given in the form of an inhaler, or it can be given through a nebulizer.
Okay.
So with an inhaler, you mentioned a spacer, and a spacer is a little tube that fits on the inhaler that you put in your mouth, or you wear a mask with it, and that helps the medicine to get into your lungs as opposed to getting a lot of it deposited in your throat or your mouth where it doesn't get into where it needs to be.
Okay.
So that's what the purpose of a spacer is.
So they use that with very young kids.
You can use it in any kid.
Any kid.
Yeah, any age you can use a spacer.
Okay.
We can use nebulizers and spacers. Usually a spacer, if they're less than like a year or two, you probably won't be able to do it. But I've seen pretty young kids be able to use a spacer fine. The other way you can do it is through a nebulizer, which is the contraptions you're talking about. And you have a nebulized solution of albuterol. It's the same medicine, it's just given in a little bit different form. And the breathing treatment takes a little bit longer. It takes like 10-15 minutes to administer a treatment. And, like I said, the medicine goes into their lungs to help to dilate their airways, open their airways so they can breathe better.
Okay. So in which case, if you're having like an asthma attack, do you use the inhaler or the nebulizer?
You can use either one. If you use it with the inhaler, you should use it with a spacer.
Okay.
If you're using it with a spacer, the treatments are supposed to be as effective as a nebulizer. A lot of times, though, if I have a child who's having a bad asthma problem, I'll usually have them do the nebulizer just because it tends to be more effective, and or I guess there's less chance of them using it improperly, like an inhaler with a spacer. Okay,
good to know. So, what about the side effects of these medications? I mean, we hear about, growth being stunted, or we can hear discoloration of the teeth. Can you talk a little bit about the side effects and what's the pros and cons?
So there's different medicines I think you're referring to. So for albuterol, the thing we just mentioned, which is the most common medicine used for an acute attack, the main side effect is jitteriness, elevated heart rate, which you see while they're getting a treatment or right after treatment, and it resolves with time.
Okay.
So it's not a serious problem.
Okay.
But pretty much everyone experiences it to a certain degree. They'll have that jitteriness and feel a little agitated right after the treatment. But besides that, that albuterol medicine is pretty well tolerated. But that's a medicine you have to take. The benefit is you can breathe, because if you don't take it, then if you're having a bad asthma attack and wheezing, you can't breathe. So that's what helps you to open your airways to breathe. The other side effects you're talking about, I think you're referring to some of the inhaled steroids, the other kind of medicines, which we'll talk a little bit about later. But those, if you're using those long term, they've shown in some studies that can affect their growth rate but it's self-limited. It's usually in the first few months, but it doesn't affect their final height. Because very little of it is absorbed in the bloodstream. Most of it's inhaled and goes in the lungs. So there can be a slight effect on the growth rate, but not the final height, not the end height of the person.
Okay, good to know that. One thing you mentioned that asthma was very difficult to diagnose in very young kids. So can newborn babies also have asthma? And a lot of times you see that mucus gets stuck in the baby's throat and they sound like they're wheezing and whistling.
Right.
So is that asthma, or is that part of the whole diagnosis issue?
Yeah, what you're talking about is not asthma, but typically what newborns get is a virus called RSV, which causes something called bronchiolitis, and that can cause wheezing in babies or newborns.
Okay.
And it's more common in the wintertime. And it's not asthma, but it causes wheezing, and sometimes it can be confused between the two. But it's a different process, but they both manifest as wheezing. So that's typically what we see in newborns, but some of those kids who have RSV or wheeze will go on to have asthma later as they get older. But they don't, typically newborns wouldn't have asthma. And it's hard to diagnose because asthma, to make the diagnosis, you have to have kind of recurrent chronic symptoms. And in a newborn, it's hard to do that.
Okay, very good.
So the question is why they may have severe symptoms of asthma when they're younger and outgrow it later in age.
Right.
So I don't think we know exactly why that happens, but it is a common thing that kids will outgrow asthma as they get older. Generally, kids who have milder cases of asthma are the ones who tend to outgrow it by the time they're teenagers or they're adults.
Okay.
Kids who have more severe cases where they're on daily medicines or they've had multiple hospitalizations, they're less likely to outgrow it than the other ones are.
Okay.
But it does happen. A lot of kids do outgrow it. I think about 60% of kids
really
will outgrow it as they get into adulthood.
That's a great percentage.
Yeah, but like I said, a lot of those are the milder cases. And if they had it younger and they started resolving or had less severe symptoms as they get older, by the age of like 5 or 6, then those are the ones who are more likely to get better as they get in their teenage years. But if they've had symptoms beyond the age of like 5 or 6, then they're the ones who tend to carry on into adulthood and continue to have it. It may not be as severe, but they will still have it.
So let's say you have a child who has asthma, had it from, let's say, 6 or 7 through 9, 10 and all that. When they're when they're a young teenager, you've taken them off all the inhalers and the Singular and everything else. But every now and then they'll complain that, I'm getting some chest tightness, or they start to wheeze a little bit. So is it okay to put them back on the inhaler for a short period of time, or is there like a course of treatment?
If they're having like wheezing or shortness of breath, then it's probably a good idea to go ahead and give them some albuterol, which is the immediate medicine that we talked about that you give when they're having wheezing in the beginning. But the long-term medicine, I would probably talk to your doctor about restarting that if you've stopped it or if your doctor stopped it. Yeah.
Okay. All right. Whether kids actually outgrow asthma or not.
Yeah, one thing I wanted to mention about outgrowing asthma, we did say there are a lot of kids that outgrow it as they get older, but even in those kids, there's always a chance that it could come back as an adult. So if symptoms have been gone for like a year or two, I wouldn't just throw away everything or all your inhalers, especially if you're going to be doing something where you think you may be if you know your triggers, like running may be one, and you can be running, then you may still want to keep your inhaler on hand. Or if you're going to be out in an area where there's a lot of pollution or something like that. So I would still keep things like that on hand, even for teenagers if they have had symptoms in many years, because there's always a chance it could come back. And sometimes the triggers can be different than what they were when they were younger. Okay. So just something to be aware of. You may not be completely clear of it, even as you're getting older. So you should always be aware there may be a chance that you may have symptoms come back.
What do you think about swimming? Because one thing that a lot of our, as parents, we know is that swimming tends to build lung capacity. So if your child suffers from asthma, but then on the other hand, and thoughts are all over the place. So if your child is swimming, and especially in winter, they're exposed to a lot of colds. So, and on the other hand, you know that swimming is good to build lung capacity. So what's the, pros and cons about that? What should you do?
So swimming or any kind of exercise, you should continue even if you have asthma.
Okay.
Just with taking the precautions that, you have your inhaler with you if you have a flare-up. But you should exercise still. There's a lot of athletes or Olympic athletes that have asthma and it's managed, and they're still able to do their normal activities. So swimming or any other running or other activity, you should still... you should not stop that just because you have asthma. Now, when you're having an acute episode, like you're having a lot of wheezing or trouble breathing, you probably don't want to do it then at that time because it may make your symptoms worse. But if you're feeling fine, then it's fine to do your normal activities like swimming or running or whatever it may be. Yes.
Okay. Doc, let's talk a little bit about how asthma is treated. What are the different kinds of inhalers, and what are the short and long-term treatment plans?
Okay. We talked a little bit about albuterol or Xopenex, which is the short-term treatment. So that's what we call a rescue medicine.
Okay.
Because when you're having trouble breathing or wheezing, that's what you do to help you get out of that, that initial phase of trouble, shortness of breath and things like that. So those are the rescue medicines.
So that helps to open your airways.
Open your airways, yes.
Okay.
Open your airways. And that's albuterol, and another one is Xopenex.
Okay.
Xopenex is similar to albuterol, except it's marketed that it will help to reduce some of the side effects that we talked about, like the jitteriness and the elevated heart rate and some of those things. And, in the studies we've done, it's been kind of inconclusive about, how helpful it is in reducing those side effects. But some parents swear by it and say, my son or daughter, they feel really jittery and agitated after treatment, but Xopenex really helps them. So they're both similar. They're both kinds of albuterol. So either one of those is fine. And like we said, it can be given in an inhaled form through a nebulizer or through an inhaler with a spacer.
Okay.
So both of those are acceptable.
Okay.
The long-term treatments are more for just maintenance, so you're not having frequent flare-ups. And those we called controller medicines.
Okay.
So those are only needed for kids who have more severe symptoms or they're having it more frequently than just occasional symptoms. So they take a daily preventative medicine, and like I said, it's called a controller medicine. And most of those are, the first line of that is an inhaled steroid.
Okay.
And that helps reduce some of the inflammation we talked about that you get, kind of just to maintain it like that so you're not having those bad flare-ups all the time. So the goal is, if you're taking that daily as a maintenance medicine, that you won't have bad asthma attacks.
Okay.
Yeah, so those are usually taken on a daily basis.
Okay.
So typically those are inhalers, also given with a spacer. Sometimes they can be, there's other ones that are given in a powder form. It looks like an inhaler, but it's a powder.
Right.
And it can be given as a nebulizer also. One that's, especially in kids, if we have little kids who are having symptoms like that, they may do a medicine called Pulmicort.
Right.
Which is a,
just gonna
probably remember that. Yeah, you probably remember that name.
Pulmicort and Flovent.
Yes, so Flovent is a steroid, inhaled steroid, which is given in inhaler form. And Pulmicort is an inhaled steroid that's given through a nebulizer. They have an inhaler also for Pulmicort, but those are all maintenance medicines. They're just different brands of inhaled steroids that help keep you from having bad flare-ups.
So is it better to be on the maintenance medicine long-term or on the short-term rescue medicines?
Well, it depends on what you need. Okay. So, like I said, if you have just mild occasional symptoms, then all you need is just a short-acting albuterol.
Okay.
But if you're having symptoms frequently, then you need to be on a maintenance medicine that you'll take. So we classify, since you brought it up, we'll talk about the classifications.
Okay.
We classify asthma according to the severity and frequency of symptoms.
Okay.
So the first level is called mild intermittent.
Okay.
And the second level we called mild persistent, then moderate persistent, and severe persistent.
I see.
Okay, so there's 4 levels of it, and we classify them according to how often their symptoms happen, how often they have nighttime symptoms. So mild intermittent is where they're just having occasional symptoms, and they can be just managed with these short-term medicines like albuterol or Xopenex whenever they need it. Those are kids who may have it infrequently, like maybe once a month and once a couple months, they may have a little wheezing episode that can be managed pretty easily.
Okay.
The mild persistent is kids who are having more frequent symptoms. They may have symptoms like 3 or 4 times a week. They may have nighttime symptoms like 3 or 4 times in a month. And those are kids that we may put on a low dose inhaled steroid as a maintenance medicine. Okay. So that's typically how we do it, kind of a stepwise approach, depending on the frequency and severity of symptoms, and we'll add those maintenance medicines if we need to. And then moderate persistent, they have more frequent symptoms, and they may need a higher dose of the inhaled steroid. And they may also need a long-term, it's called a long-acting beta agonist, which is something that dilates the airways, but it lasts longer than the albuterol. Albuterol is short-term, but this one is longer-term. And that's the medicine you may have heard of called Advair. And there's a few other ones like that, like Dulera, Symbicort is another one. But those are given usually as a combination. It's a combination of steroid medicine and a long-acting beta agonist. So those are given for more severe cases of asthma. Like we said, maybe the moderate persistent or severe persistent, and we'll give those. So we like I said, we do a stepwise approach. You mentioned Singulair before. That's usually a chewable tablet, and that works in a different way, but that's sometimes given as a maintenance medicine as well, in addition to these inhalers. So if you're not home, then whoever's taking care of the child, like a babysitter or whatever, should be, if your child has asthma, you should train that person to give a breathing treatment. If you're at school, then you should have your medications at school. So the nurse knows how to do it. They usually make an action plan from the physician where they know, or tells them which medicines to give when they have an illness. So if your child has asthma, there shouldn't really be a situation where you can't give them that medicine quickly if you need to. Wherever they go, you can carry an inhaler with them. If they're at school or whatever, or if someone else is watching them, then they should have either the nebulizer machine or an inhaler accessible to give them the treatment. And for some reason, if it's not available and you can't, then you should take them to the ER to get treated as soon as possible, especially if it's a bad episode.
Can asthma actually be triggered in your sleep?
It depends on what's in your environment. But it does tend to be worse at nighttime, though. So, and when we're talking about the classifications, that's how we classify it, is according to nighttime symptoms of coughing or wheezing. And a lot of times it's coughing that wakes them up out of their sleep at night. So that's a lot of times parents will tell me, there's sometimes in undiagnosed asthma, they'll be like, he's always coughing at night. And he wakes up out of his sleep and he has to go drink water. So that's a common symptom that we see in kids with asthma, is nighttime coughing or wheezing.
And you mentioned an asthma action plan. What is that?
An asthma action plan is something that your pediatrician will make for you, or sometimes your allergist does it also. The schools often have it. And that's basically what you're supposed to do when your child has symptoms. So it's usually, the common ones, they have it as like, they'll list it as a green light, yellow light, and red light. And green is when you're doing fine. You just take your daily maintenance medicines, which may be like Flovin or Pulmicort, like we talked about. And maybe if you have allergies, you may take your allergy medicines. The yellow is when you may start having an illness, you may start wheezing a little bit, and then you need to step up. You need to start the bronchodilators or the albuterol, and you step it up. And it may be that, or maybe some other thing. Sometimes, one thing we forgot to mention is a lot of times we treat asthma attacks with oral steroids also. So we talk about inhaled steroids more for maintenance, but for acute attacks, we also give a short burst of steroids, which is like prednisolone, which they'll take for anywhere from like 3 to 5 days. We'll give that to them, and that'll help their wheezing quite a bit as well. So that may be part of their action plan. Then the red may be a severe attack where they're really labored and having a hard time breathing. And in that case, you give them a albuterol treatment and then take them to the ER or take them to the hospital. I was just going to ask you that question. So your child is having difficulty breathing. Should you give them the nebulizer, or should you take them to the ER? It depends on how severe it is. So if they're having just some wheezing and a little bit of trouble breathing, you can give them a treatment and see how they respond, and they don't respond to it, then you should take them in to be seen. If they're having very severe shortness of breath, they're having another other symptoms we may see in severe symptoms is they may have trouble talking. They're having so much trouble breathing that they may not even be able to speak in a proper sentence because they're having so much trouble with their airway obstruction. So if you're seeing a really severe exacerbation where they're just having a really hard time breathing and labored, then in those cases, then you should take them in right away. And maybe if you have an inhaler, you can do it on the way there in the car. Or if you call an ambulance and you call 911, then they'll give you, as soon as they see you, they'll give you a breathing treatment right there, or in the ambulance on your way to the hospital.
Okay. What are some of the complications from asthma?
Well, most of the complications have to do with, affecting your lifestyle. We talked a little bit about that, but, days missed from school, parents missing days from work can affect kids can affect their schoolwork. They may be tired or fatigued, lack of sleep, especially if they're having a lot of those chronic nighttime symptoms. They may not be resting well, and that can affect their behavior and it can affect their grades. So those are the kind of complications that we'll typically see.
But can asthma actually end up scarring your lung? And also when you, let's say you have it in childhood, are you at risk for something like COPD or chronic obstructive pulmonary disease as an adult?
It won't turn into COPD. COPD is a different kind of a disease. It has a similar obstructive component to it, but it's not the same thing.
Okay.
So asthma won't turn into that.
Okay.
So, but you may have symptoms into adulthood, and like I said, it's not going to turn into this different thing, but you may be at a little bit higher risk to get things like pneumonia and other respiratory illnesses, especially if you're getting a lot of frequent exacerbations, but it's not going to turn into COPD though. Okay.
And not scarring, no scar tissue or anything like that?
Not scar tissue that I know of or anything I've read about, but they can have changes in the airway at the level of the cellular level when they have asthma symptoms.
Okay.
So, and that's why I mentioned that, a lot of times, even as they've outgrown it, later on in life, the symptoms may always come back with different triggers. So, but there are some changes in the airway that happen when you have chronic asthma symptoms.
Okay, good to know. What do you think? Does food have any bearing on asthma?
It can. If there's things that you're allergic to, there are certain foods that you're allergic to, then that can cause you to have your asthma attack.
Oh, really?
Yeah. So you should avoid those things that you may be allergic to.
Okay.
If there are things you're allergic to, or you even suspect you may be allergic to, then don't give them at that time.
So when you actually take your child to an allergist, and they do your lung function test and your spirometry,
right?
Should you get allergy testing as well?
You don't have to, but a lot of times they will. If you're going to see an allergist and you're having asthma symptoms, a lot of times they'll do allergy testing also. They don't have to do that. The spirometry is, like I said, what they use to diagnose it. But a lot of times, like we said, these people, the patients that have this, they also have eczema and allergies. So a lot of times they may do that just to see if there's a trigger, what the triggers may be, if it's some sort of allergen. And like we talked about, those sometimes they can be things like animal dander, like cats or dogs. Sometimes it's dust mites, cockroaches.
Oh,
that's a common one.
I would think everybody is allergic to cockroaches.
Yeah, so this is a different kind of allergy, but yeah, those are common things: dust mites, cockroaches, animal dander, molds, pollens, things like that. So if you're doing that whole panel of environmental allergies, then that may help you know what your triggers are for asthma, and then so you can avoid them and take the measures to prevent those things.
Okay. In your child's bedroom, I've heard this again, that you shouldn't have drapes and you shouldn't have carpeting if your child suffers from asthma.
Yeah, if you have a lot of bad asthma symptoms, then you probably want to avoid carpet and things like stuffed animals. And you should, if you do have carpet, you want to clean it frequently with a vacuum with a HEPA filter to try to avoid. And the allergens are mostly these things we talked about, like dust mites and stuff like that. The other thing you'd probably want to do is get covers for your mattresses and for your pillows.
I've seen them, those dust mite covers.
Yes.
So do they work?
Yes, they do work.
Okay.
Yeah, it keeps, because if you're allergic to those things, which many people are, and it triggers their asthma symptoms, then you should do that. You should cover up your, pillows and mattresses. And vacuum your carpet frequently. And if you have a choice to remove the carpet, I've seen parents actually do that, and kids who've had really bad asthma symptoms is move to a house that doesn't have any carpet for that reason.
Okay.
And we mentioned another thing that sometimes parents don't think about is stuffed animals.
Oh, yes.
Yeah.
Absolutely. We had to do that with my older one because he loved to sleep with like 12, 15 stuffed animals. And then we found that he was just coughing incessantly, and we removed them and it was gone.
It was better, yeah.
Yeah, absolutely. What about air purifiers? Do they help if your child suffers from asthma?
I don't know I haven't read any studies by air purifiers helping for that. It may help for things like if they're having colds or allergies, or a humidifier may help just to have humidified air so they can breathe a little bit better.
Okay.
But as far as making a change in how asthma happens, I don't think it'll make a difference for that.
Okay. What kind of lifestyle changes does a child with asthma need to make?
So we mentioned some of those as far as in your house, you should get the covers for dust bites, and we talked about carpet. The other thing is if you have pets, some people are allergic to, not everyone, but some people with asthma may be allergic to the dander from pets like cats or dogs. So you want to probably get rid of your pets if they have if it's a trigger for their asthma symptoms.
Okay.
But you just want to make sure that they're eating a healthy diet. That they're not overweight. Actually, being obese is a risk factor for asthma. I don't think we mentioned that before.
Right, the risk factors.
Yes, so obesity is a risk factor for asthma. So keep a healthy weight, healthy diet, get regular exercise, get your flu vaccine. That's also important.
What's the best time to get a flu vaccine? Like, should we get it September or October?
As
or
soon as it's
later?
available.
Oh,
that's
really?
the best time.
Okay.
Yeah, as soon as you can get it, you should get it.
Oh, and I have another question talking about flu vaccine. They say that kids who have asthma shouldn't get the inhaled flu vaccine. You should get the shot.
Yes.
Is that true?
Yes, it's true. And the reason for that is the inhaled version of the flu vaccine is a live virus.
A live virus.
Yeah, the shot is not a live virus, but the inhaled one is a live virus, and we don't give it in people who have respiratory problems like asthma. If they've had a problem in the past year, we don't give it in like people who are pregnant. So we're just a little bit more selective in who we give it. We don't give it in kids less than 2, whereas in a regular flu vaccine, a shot you can get it at 6 months.
So what will happen? It can trigger an asthma.
Yeah, potentially.
Attack.
Yeah, if you're taking a live virus, there's potentially more chance of side effects from the vaccine.
Okay. So and roundabout when is the flu vaccine available?
It depends on the season when the manufacturers put it out, but it can be anywhere from the end of August to September usually.
And is that something done at your office?
Yes, we do flu shots usually end of summer or September. As soon as we get it, we start giving the vaccine. Okay,
and you do both the nasal, what is it, the nasal spray?
Flu mist.
Flu mist,
and the shot. Okay. And, depending on the child will decide, at their age, will decide which one to give them.
Okay. Is asthma more common in boys or in girls?
It's a little bit more prevalent in boys than girls. The reason for that, I'm not sure why. But from the research, it's a slightly higher prevalence in males.
Okay. And what I think we sort of glossed over the risk factors. You mentioned obesity and hereditary.
Cigarette smoke is a major risk factor for that. Being around like pollution, we talked about, being in big cities or something. Those people may have more asthma attacks, and hereditary we talked about. So having a parent that has it or a sibling that has it really increases your risk of having asthma. I would say those are the major risk factors for it.
What about, I know you mentioned obesity as well, but what about kids who who have a low birth weight, who are born with a low birth weight or at a low birth weight?
Yeah, like premature babies. Yeah, those kids tend to have more asthma symptoms also later in life.
Okay.
And it has to do with their lung development. Okay. Because they don't have, depending on how premature they are, they may not have full lung development, and that may affect them later in life and cause them to have asthma symptoms, especially if they've been on a ventilator. If you have a premature baby who's been on a ventilator machine for a few weeks or whatever it may be, then they're at higher risk for having those symptoms later in life.
Is there any association between GERD and asthma?
That is a risk factor too.
Okay.
Yeah, so GERD is a risk factor for asthma.
And
as
maybe
well.
you can tell our listeners what is GERD.
GERD is gastroesophageal reflux disease.
See, it's a difficult word, so I had you say it.
Yeah, yeah, it's just reflux.
Okay.
So those are things that you would treat with like Zantac or Prilosec. Common problem for many adults, especially people that like to eat Indian food. But that's a risk factor for asthma as well. Maybe you might see that more in like older kids, like teens or adults.
Okay.
One thing that is important is that you see your doctor regularly. Kids who have asthma, we like to check them periodically to see how they're doing.
Is that once in 6 months, a year, 3 months?
It depends. It can be somewhere between 1 to 6 months, depending on the severity of their symptoms. And it's just really up to the doctor, depending on, their past history and how bad their symptoms are. So it's important that you keep your doctor's appointments, that you see them periodically. And it's also important that you take your medicines as directed. Like if your doctor puts you on a controller medicine that's supposed to be taken daily, then you should take it daily. If you feel like you don't need it, then you should, visit with your doctor and discuss symptoms. But it's important that you adhere to the action plans and the medicines and all those things. That's very important in maintaining asthma so it doesn't flare up or cause serious problems where you end up going to the ER or get hospitalized.
So if you're on a controller medicine, can you just stop cold turkey, or do you have to actually wean yourself off these meds?
I've seen it done both ways. You can wean it sometimes, like you may go to a lower dose. If they're already on a lower dose, they may just stop it if they're not having any bad symptoms and see how they do over a few weeks.
Okay.
Usually if they have more severe symptoms and they're on a higher dose of controlled medicines, they usually wouldn't stop it right off the bat. You'd probably want to step down to a lower dose, see how they do, and then slowly wean it off.
Okay, excellent.